Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for a commute, coffee break, or whenever curiosity calls. I'm Saud, your host for today's episode, and we are joined by Mohamad Behairy to discuss some rather common skin conditions.
Thank you, Saud, for such a wonderful introduction. Hi, everyone. I'm very excited for today's topics because almost every human on this planet has dealt with at least one of these: acne, rosacea, or hair loss.
Yeah, rosacea, alopecia, and especially acne are quite common. So let's discuss their pathogenesis, clinical features, variants, and treatments. Let's set the stage with a classic case we see almost every day.
Let's imagine this. A 16-year-old boy comes with multiple whiteheads on his cheeks, blackheads on his nose, and tender red papules on his chin. He's frustrated, embarrassed, and thinks it's getting worse despite washing his face more often.
This looks like a typical case of adolescent acne.
It is, in fact. Acne is inflammation of the pilosebaceous unit, which is made of the hair follicles and its oil glands. These units are densest on the face, chest, back, and upper arms, hence why those are the areas that usually develop acne.
Acne usually peaks around adolescence, right?
Yes, the peak is around 12 to 24 years of age. It may also be normal to find it during the pre-adolescent stage, so that would be around 7 to 11 years old. Even infants can get acne. However, if you see acne in a child below the age of 7, you should immediately start worrying about some possible underlying problems like hormonal issues, endocrine disorders, or androgen excess.
So, acne in a little kid is a red flag. Alright, now let's break down the pathogenesis of acne.
Let's go for it. It all starts with the follicular hyperkeratinization and increased sebum production. After that, we would have inflammation by the Cutibacterium acne. All of this would ultimately lead to rupture of the pilosebaceous unit.
Okay, so let's take it step by step. First, we started with follicular hyperkeratinization, with increased sebum production. But why is that?
The follicular hyperkeratinization is when the keratinocytes become cohesive and form a plug, which gives us these comedones. On the other hand, the increased sebum production is due to androgens, which also make the sebum thicker.
So, comedones and sebum. And you said something about inflammation as well.
I sure did. There is inflammation by a group of bacteria called Cutibacterium acne. These bacteria convert lipids to free fatty acids and secrete cytokines such as interleukin 1 and TNF, which all ultimately lead to inflammation.
A plug, sebum, and bacterial inflammation. That's a lot of pressure on the pilosebaceous unit.
It sure is, and all of this may ultimately make the pilosebaceous unit rupture, leading to papules, pustules, nodules, pseudocysts, and even in severe cases may cause scarring or post-inflammatory hyperpigmentation.
So, comedones come first, from the curtain plug, and all these other presentations appear later on.
Absolutely, the primary lesion here is the comedone, and that is why the presence of these comedones is what defines acne. Without them, we would not call it acne.
Hmm. Now, are comedones whiteheads or blackheads?
Actually, both, depending on whether it's an open or closed comedone. Closed comedones, where the opening is really tiny, are the whiteheads, while the open comedones, which have a large opening, are blackheads. They're blackheads because when it's open, the lipids and sebum inside are exposed, and the air would oxidize them.
Alright, Mohammed. Everyone always asks this question: what actually makes acne worse? Because people blame literally everything.
That's a really good question, Saud. And honestly, a lot of things can push it over the edge. Your genes set the stage, and hormones, especially androgens, love to stir things up. Stress alone can make a mild case flare up. You also see some girls have their acne getting worse right before their period. Even diet plays a role for some people. And don't forget, cosmetics. Heavy or oily products can easily clog things even more. And medications like steroids, lithium, phenytoin, INH, iodides, even cetuximab, all of these can trigger acne.
So, if someone gets acne at the age of 13, 14, when are they usually out of the woods?
Well, most people start improving around their early 20s. Some people are unlucky and it follows them into their 30s or even 40s. And even when the active acne goes away, the marks and scars can linger around unless treated early.
And there are several types of acne, right?
Absolutely. The classic one is acne vulgaris, the thing most people think of. But then you have more dramatic forms like the acne conglobata and the acne fulminans. There is also chloracne from chemical exposure, as well as acne exoriae, which is when patients pick on their skin.
So treatment really depends on what type and severity we're dealing with.
Right. If it's mostly comedones, aka blackheads and whiteheads, we lean toward topical retinoids or other exfoliating agents. If there's inflammation, however, that's when we would add antibiotics, either topically or orally. When hormones are involved, you know that jawline acne that flares with the menstrual cycle? That's when we would use oral contraceptives or spironolactone. And severity guides practically everything. Mild cases stay topical, while moderate or severe ones might need systemic therapy. And those deep, painful nodular cystic cases, they usually end up on oral isoretinoid.
Let's take a quick practice question before moving on. A 15-year-old girl has whiteheads and blackheads everywhere, a few papules and 0 nodules. She just started heavy, oily makeup and she's stressed about exams. What specific finding in this patient confirms that it is acne?
Easy. Comedones, aka the white and blackheads. If you see comedones, you're in acne territory.
Great. So we are done with acne now. Let's move on into our next skin condition. Imagine a 45-year-old woman walking in, cheeks always red, worse whenever she drinks hot coffee or eats spicy food. Exercise, alcohol, stress, everything flares it. And she's seeing tiny visible vessels.
That is classic rosacea, central facial redness, and telangiectasias with specific triggers. Rosacea is basically a chronic inflammatory condition of the central face, usually starting around 30 to 60 age range. You see persistent redness, sometimes papules and pustules, as well as little blood vessels, thickening of the skin in some people, and even eye involvement. And the course is relapsing. It comes and goes as flare-ups.
So if rosacea also has papules, pustules, and inflammation, how do we differentiate it from acne?
One word. Comedones, comedones, comedones. Rosacea never has them. If you see comedones, it is acne. End of the story.
Okay, great. Let's break down the pathogenesis of rosacea.
Sure thing. It's a mix of genetics, nervous system involvement, and changes in the skin microbiome, especially an increase in the Demodex mites. In these patients, the skin barrier isn't as strong as it should be, and the innate immune system is overactive with higher TLR2, higher cathelicidins, higher kallikrein 5, and more mast cells. Even the adaptive immunity joins the party with a Th1-Th17 dominance. Th17 especially ramps up LL37, which makes inflammation even worse.
So, 1. Weak skin barrier. 2. Inflammatory cytokines. 3. Th1, Th17. What are some things that might trigger flare-ups?
That's a very good question. Anything that makes you warm. So things like heat, hot drinks, spicy food, alcohol, exercise, and even stress, all of these can make it worse.
And how do we manage it?
That's a good question too. First, you want to avoid triggers. But let's say it's already happened. You would perform gentle skincare, and for medications, we would use topical metronidazole or azelaic acid. These are great starters. Oral antibiotics also help when it's more inflammatory. For the telangiectasia, aka the visible vessels, lasers and light therapy work really well. And finally, if their eyes are involved, you treat that too.
Thank you, Mohamad, for explaining the management. Let's take another practice question. A 30-year-old woman with facial redness that flares up after exercise or consuming wine. She has papules, but no comedones. What is the diagnosis?
This is a classic case of rosacea. Remember, redness with no comedones.
Last case of the day. A 30-year-old woman has been losing hair in the shower. She had major surgery 3 months ago. Now, her hair feels diffusely thinner.
That's alopecia, And in this patient, it was probably triggered by the stress from her major surgery. Alopecia is simply abnormal hair loss from areas where we would normally have hair.
Before we dig deep into the disease itself, let's step back and discuss the types of hair that we have in the human body.
Let's go for it. You have lanugo, which is the fine fetal hair. Then there's vellus, that soft, non-pigmented hair. And finally, terminal hair, which is the thick, pigmented, hormone-driven type of hair that you can find on the scalp and beard.
Now here's the question, Mohamad. Does hair have a specific growth cycle, or is it kind of just growing?
That's a very good question, Saud. It actually has a very specific cycle. So hair moves from anagen, the long growth phase, to catagen. After that, it moves to telogen, which is the resting phase, and finally to exogen. That is where the hair basically starts to shed. You know, shedding around 100 to 200 hairs a day is actually completely normal.
So anagen to catagen to telogen to exogen. Okay, now back to alopecia. Clinically, we divide alopecia into scarring versus non-scarring.
That's absolutely correct. Non-scarring types keep the follicles intact, while scarring types destroy them, meaning permanent loss if not caught early. Non-scarring includes androgenetic alopecia, alopecia areata, telogen and anagen effluvium, trichotillomania, and inflammatory tinea capitis. On the other hand, scarring forms include things like DLE-SLE, lichen planopilaris, folliculitis decalvans, and folliculitis keloidalis. The moment you see a smooth scalp with missing follicle openings, that's when you worry.
Let's start with the common one, androgenetic alopecia.
That one is driven by DHT. So basically, testosterone gets converted to DHT, and that shortens the growth phase, making the hair thinner and shorter over time. Men can get it any time after puberty, while women often around menopause. If it starts too early or progresses too fast, that's when we start to worry.
And how do we treat this condition?
Beautiful question. Topical minoxidil, finasteride, and spironolactone are the way to go, and in some cases, hair transplant. But the key message to patients is consistency, because improvement is slow, so they shouldn't get discouraged along the journey.
Another cause of hair loss is telogen effluvium. What does that even mean?
Great question, Saud. That's basically when a bunch of hairs jump straight from anagen into telogen at once. So shedding increases because telogen is the stage right before the hair starts shedding. It happens after postpartum, surgery, acute illness, crash dieting, thyroid issues, medications, or even emotional stress.
And the timing of these triggers is important?
Absolutely. The shedding starts about 3 to 4 months after the trigger because telogen lasts around 3 months and the shedding starts right after it exits telogen. Now, when you see a patient and you suspect telogen effluvium, you do something called the pull test. In this case, it would be positive with club hairs, which are literally hairs with club-shaped roots.
So does it also affect the hairline like androgenetic alopecia?
The thinning is diffuse, so in this case, the hairline is spared.
Okay, now on to our last type of hair loss and the last segment of today's episode, alopecia areata.
Alopecia areata is an autoimmune, non-scarring type of hair loss, and it shows up as sharply defined patches. It can hit the scalp, beard, brows, lashes, literally anywhere, and it's associated with other autoimmune diseases like vitiligo and thyroiditis.
And the hair loss shows up in different patterns, right?
Absolutely. It has different patterns depending on its subtype, so it's either patchy, totalis, universalis, or ophiasis.
They sound very difficult to handle. Does it have a good prognosis?
While most patchy cases grow back on their own, only about 5% of them progress to totalis or universalis. Unfortunately, though, relapses are common. There can be a poor prognosis, however, if it's early onset or has a long duration. The more widespread the patterns, the worse the prognosis. So patterns like the ophiasis, totalis, or universalis. And finally, the presence of atopy with the alopecia. That's also relatively worse.
So based on my understanding, and correct me if I'm wrong, since it is autoimmune, we would treat it with steroids, right?
That's absolutely correct, Saud. That is a big part of it. We use intralesional steroids, topical immunotherapy like DPCP or anthralin, and sometimes systemic steroids or other immunosuppressants. Basically, as you said, steroids.
Last practice question before we wrap it up. A 20-year-old woman has been shedding hair for a month. She had COVID 3 months ago. Her hair pull test was positive with club hairs, and her hair showed diffuse thinning, no scarring or patches. What is the most likely diagnosis?
The answer is telogen effluvium. Why? It's because the hair is shedding 3 months after the trigger, which in this case is the COVID infection.
Great. Let's quickly wrap up today's episode.
We explored acne, rosacea, and alopecia. Acne is basically inflammation of the pilosebaceous unit. You must see comedones to call it acne. The whole thing comes from hyperkeratinization, extrasebum, bacterial inflammation, all of which eventually lead to the rupture of the pilosebaceous unit. Triggers are hormonal, genetic, stress-related, and medication-related. Treatment always depends on the severity and type of acne. Rosacea is a chronic inflammatory process of the central face, triggered by heat, alcohol, and spicy meals. And the biggest difference from acne is the total absence of comedones. The immune system plays a huge role, and the management ranges from lifestyle changes up to systemic therapy and laser. For alopecia, we talked about the different hair types and the hair growth cycle. Then, we defined alopecia as abnormal hair loss, divided into scarring and non-scarring. Then we talked about androgenetic alopecia, which is DHT-driven, and telogen effluvium, which shows up 3 to 4 months after a trigger. And finally, alopecia areata, which is autoimmune. Also remember that scarring alopecias need early recognition to prevent irreversible hair loss.
And that brings us to the end of today's episode.
We hope this simplified these common dermatology topics.
Thank you for guiding us through it, Mohamad.
Thank you so much, Saud, for hosting this wonderful session. It was a pleasure to be here today.
My pleasure. Thank you everyone for tuning in, and see you all in the next episode.